Good evening, everybody. On behalf of the organizing committee, I welcome you all to the TANUVAS Global Veterinary Trauma Critical Care and Emergency Webinar Series 2 on fluid homeostasis and electrolyte imbalance in small animal critical care and emergency. Now I invite Dr. A. Arun Prasad, Organizing Secretary of this webinar, Resident Veterinary Officer and Head, to deliver the welcome address.
A very good evening, good morning, namaskar, vandanam, vanakkam, and greetings to everyone. It gives me immense pleasure to welcome you all to this TANUVAS Global Veterinary Trauma and Critical Care Emergency Webinar Series 2 2021 on fluid homeostasis and electrolyte imbalance in small animal critical care emergency, organized by Resident Veterinary Services Section, Directorate of Clinics, MADRAS Veterinary College, Chennai. On behalf of the organizing committee, I heartily welcome our Honorable Vice Chancellor, TANUVAS, Chennai, who has kind enough consented to preside over the event and deliver a webinar address in spite of his hectic official commitments. We welcome you, sir. We did like to extend our special welcome to our guest speaker, Dr. Carey Hemmelgarn, DVM, Diplomat, American College of Veterinary Emergency and Critical Care, USA, an enthusiastic personality, a co-founder of Intensive Vet, a specialized online education for veterinarians and small animal criticalists, who has readily accepted our invitation to share the knowledge to the fellow fraternity in spite of her busy practice. We welcome you, Dr. Carey, for this event.
Thank you.
Thank you. We would like to extend our special welcome to our Director of Clinics, TANUVAS, whom under his motivation and guidance, conducting this webinar in a successful manner. We also extend our warm welcome to our Deans of the College, Constant Unit of TANUVAS, University Officer, Head of the Departments, faculties of TANUVAS, and other faculties all over the India and abroad. I am so delighted and excited to welcome our participants across the world to this grand event. I welcome the members of the organizing committee and Mr. Karnanidhi, Vice President Alembic, Dr. Santosh, and his team for Information Technology Partners, Alembic India Limited. I am excited to have all you to this wonderful event and hope that today, ideas and discussions around the ways can make our insight for better approach in fluid therapy in critical care and ill patient and to provide a veterinary care to pets. Once again, on behalf of our organizing committee, we welcome you all to this event. Thank you, one and all.
Thank you, sir. Now I invite Dr. L. Nagarajan, Professor and Head, Department of Clinics, to give a short introduction about the webinar.
Hello, everyone. Good evening from India. And as you know, that the Tamil Nadu Veterinary and Animal Sciences University has been organizing a series of webinars, global webinars for the very benefit of the practitioners, faculty, and also the students. In this series today, there's going to be a webinar on the homeostasis, fluid homeostasis. And as you know, that water is elixir of life. So without water or fluid, normal body function become chaotic. And fluid therapy is important for many medical conditions, and especially in critical care and emergency and critical care. Prompt resuscitation with intravenous fluids for hypovolemia and other electrolyte abnormalities. Optimizes the microvascular parameters such as blood pressure, etc. And fluid selection depends on the patient needs, such as the volume of the fluid and rate of fluid to be administered, and also the type of fluid. And they must be individualized, tailored to each patient. The method of fluid administration also influences the outcome of the case. The veterinarian should familiarize themselves with the pathophysiology of various diseases that affect the animals, small animals especially, and choose the right choice and technique of fluid therapy for successful outcome. So I'm sure that this webinar will impart quality update on the fluid and acid-base homeostasis in small animal patients under emergency critical care and benefit the practitioners, faculty, and the students all over the globe as well. Thank you very much.
Thank you, sir. Now I invite Dr. C. Balachandran, Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University, to deliver the presidential address.
Good evening from India and greetings from Tamil Nadu Veterinary and Animal Sciences University. The guest speaker, Dr. Carey Hemmelgarn. The organizing committee here headed by Dr. S. Balasubramaniam, Director of Clinics. The organizing secretaries, Dr. Narendra Prasad, Dr. Vijay Kumar, Dr. Vijay Anand. And the head of the Department of Clinics of this prestigious Madras Veterinary College, Dr. L. Nagarajan. Other colleagues, friends, and my dear participants from India and world over. This university under the Directorate of Clinics, supported by various clinical departments. We had 4 well-established colleges in the state and 3 more are coming up. So we decided to have this type of webinar, and also it has come handy during this COVID period. We could organize around 8 webinars. This is the 9th one. And also it has given way for inviting various eminent personalities who are expert in their field to deliver the lectures for the benefit of our own students, faculty members, and practitioners. And really it has given a lot of inputs in gaining the knowledge and updating their insights in the specific areas and fields. So one such one is today they are focusing on the fluid homeostasis and electrolyte imbalance in small animal emergency and critical care. So once again, this college, which has been having this critical care unit for long, and it is being strengthened in different ways so that it can cater to the needs of our valued clients here. So naturally, this system requires aggressive IV fluid resuscitation in emerging as well as critical care. So it is warranted in many cases when there is acute onset of illness or systemic signs of shock. It is hypovolemic or distributive or septic in nature. So I am given to understand certain history of this. It starting in 1628 when William Harvey described the circulatory system. It was later rapidly accepted. And the cholera pandemic, which has led to injecting water in the circulation to replace lost fluid by or Hermann. And then the reason has also been found out well by Dr. Shagnishi on the hemoconcentration that is occurring in the cholera. So he was recommending IV fluids to restore blood to its natural specific gravity and restore its deficient saline matters. So then the kind of equipment on the IV set, then it was simply devised as an open material in 1930s, later gone into a vacuum sealed glass bottles. And Sir Christopher Wren, he devised the first infusion pump for intravenous fluid administration. So that has formed the prototype for the modern IV pumps. So earlier they used even pig's bladder and also writing skill for this purpose. So later in 1960s and also after a couple of decades, then plastic bags have come into use for the purpose, and it has become very popular in hospitals today. So this fluid and electrolyte therapy has gained importance, and there are recommendations for use on quantity and type of fluids and or electrolyte to be used for disease conditions by the International Fluid Academy. And then fluid therapy is advocated for rehydrating the patient, maintenance of fluid homeostasis, replacement of invisible volume, and replacement of ongoing fluid loss. So we have to take, as it is well said in the opening remarks, on the choice of fluid and discretion that are based on interpreting the clinical pathological parameters here. So, for example, it is quoted that in case of anemic patient, concomitant hypoproteinemia may seem normal if the patient is dehydrated. So several things I think you'll be hearing large on this, the conditions and kind of things you may require. So it has been listed here long. You will hear from the speaker. So in the recent years, guidelines for fluid therapy in critical care is resuscitation, optimization, de-escalation, chloride restrictive fluid therapy, early enteral nutrition, avoidance of synthetic colloids, and avoiding the fluid overload. So the fluid of choice includes use of crystalloids, colloids, whole blood, and blood component therapy. And for the benefit of the participants, this Madras Veterinary College Hospital has blood bank to serve for the veterinary patients. I think they've also gone for an app for this purpose also. So in view of the specificity on use of type of fluids and to throw light on the various aspects of fluid therapy in small animals. So this webinar has been arranged. Hope it will be beneficial to our fellow veterinarians and graduates and veterinary faculty. I congratulate the team behind this program and extend my heartiest wishes to all the eminent research scientists around the globe for their contribution as resource speakers in the webinar. And I could see that more than 1,800 have registered for this webinar. Wishing you a great success on this occasion, and thank the organizers for giving me this opportunity. Thank you.
Thank you, sir. Now the organizing secretary, Dr. A. Arun Prasad, will introduce the speaker of today's webinar.
So, a very good morning, Dr. Carey Hemmelgarn. So, Dr. Carey Hemmelgarn is a co-founder of Intensive Vet, a company specialization in online education for veterinarians and a small animal criticalist. She has an experience as an experienced criticalist. Dr. Hemmelgarn is currently working in New Jersey at Blue Pearl Veterinary Partners, New York, USA. Dr. Hemmelgarn likes the fast pace of emergency and critical care medicine, and that her day can change on the moment's notice. Her particular clinical interests include polytrauma and septic patients. So Dr. Hemmelgarn attended veterinary school at WSU, Washington State University, Pullman. After veterinary school, she completed a small animal rotating internship and then a 3-year residency program to specialize in emergency and critical care medicine. And Dr. Hemmelgarn has published to her This one, 2 papers on the pathophysiology and treatment of heat stroke in small animal patients. When not working, so she won't be quiet. She'll be doing a special, this one hobbies like running, spending time outdoors. She had completed a multi-off marathon race and a new NYC marathon in 2014 and 2019. So married to another veterinarian, she and her husband have an active lifestyle and enjoy traveling. The Dr. Hemmelgarn household is home to the number of animals. She houses a lot of animals with her and take care of them, including Louie, a Rottweiler, and 3 cats named Ellie, Ricky Bobby, and Iggy. So it's have to have Dr. Carey for this webinar. So over to Dr. Carey. Thank you.
Over to you, Dr. Carey, for the lecture.
Okay, thank you so much. So I'm going to start sharing my screen.
Yeah.
Okay. Okay, hopefully all of you guys can share my screen and can also hear me. So I just wanted to thank everyone for having me today. I know it's late in India time, it's early in New York time. So I'm going to go a little bit through who I am and why I'm here to talk to you guys today. So I'm a small animal critical care specialist, similar as what you guys introduced me as. I've been in practice for the past 12 years. I'm currently practicing in a corporate referral hospital, seeing emergency and critical care cases. I will see the door and see emergency triages. I also manage our ICU and our critical care caseload. I'm the co-founder of IntensiVets. It's an online training corporation for veterinarians and veterinary technicians. It specializes in designing courses that are interactive and educational for the veterinary industry. Our current courses include CPR training, high quality, high volume spay and neuter programs for shelters, shelter disease medicine outbreak, and introduction for shelter medicine for veterinary technicians. All of these are web-based courses that are designed to improve the quality of care and the treatment of animals in shelter situations and improving the quality of CPR in veterinary hospital situations. And the website is www.intensivets.com if anyone's interested in learning more about our company. So we're going to go into more of the important details today. So today we're going to talk about fluid therapy. And there was a little bit of a history introduction today, and I will recap a little bit of that. So in the 1800s, they started to notice that there was hypotonic salt solutions, and there was some talk in the medical field about using hypotonic salt solutions. In 1882, Dr. Hamburger first started developing a 0.6 and a 0.9 saline solution. It's very impressive seeing we still use the 0.9 saline solution. And so I do always find it very interesting that something that was created so long ago is still very relevant in our medical field. In 1883, Sidney Ringers created the Ringers solution. There's a little bit of a gap in the history of fluid therapy and making, but in 1932, they started to create lactated Ringers, and it was the first time that they started using a bicarb buffer in their fluid solutions. In 1940, Carl Wiggers identified hypovolemic shock and started to utilize some of these fluid therapies in the treatment of it, and they started to see improved mortality in shock situations. And then we started to develop more of the colloid and synthetic colloids in the 80s to 90s. And now we're going to talk about what our current theories of fluid therapy are. We're going to break down a little bit into pathophysiology. So our body is created of about 40% of dry matter and 60% of our total body water. Our total body water is further broken down into an extracellular space and an intracellular space. The intracellular space takes up about 2/3 of our body water, and our extracellular space takes up about 1/3 of our total body water. Our intracellular fluid is further broken down into plasma and our interstitial space. So if you think about when we give fluids to our patients, we want to think about where they're going, what we're trying to replace, and where we don't want them to go. So I think it's always important just to take a step back and look at the pathophysiology of where we are and what our body is made of and how we can further target our fluid therapy for that. So this is our normal body composition of our extracellular space. So we are breaking it down between our extracellular fluids and our intracellular fluids. Normal sodium for our patients should be on average around 145, and intracellularly it's much lower. Our potassium is opposite, and it's lower extracellularly compared to intracellularly. Calcium is about roughly the same, but slightly lower in our extracellular space. Magnesium is higher intracellularly, chloride higher extracellularly, and bicarb is higher extracellularly. I think it's important for us to have just this filed away somewhere in our memory, because in the next couple of slides, we're going to talk about what fluid therapy options we have. And if we know what our body is meant to have, then we know what fluids to target to try to make it as close to normal as possible. So when we talk about fluids, we have two general definitions of them. We talk about crystalloids and colloids. We're going to break down the category of crystalloids first, then we'll break down colloids. We'll talk about pros and cons of both of them, and then we'll talk about options on how to treat them, what doses you would prescribe for them, and then also we're going to break it down into some case studies at the end. So for our crystalloids, there's lots of options, but we're going to further break them down a little bit more in detail. We're talking about having a balanced and an unbalanced. Balanced means that it has a bicarb precursor and it's as close to our extracellular fluid space composition as possible. Hydration status is broken down between a replacement fluid and a maintenance fluid. So some of you guys may not have looked at these bags closely, but it is something when we talk about lactated ringers, we talk about that being a replacement fluid, but there are things like Normasol R, which has a replacement sign after it. And then there's a Normasol M, which is a maintenance. So we're going to talk about different reasons that you would use maintenance fluid versus replacement fluid, which definitely has a larger part in human medicine than it does necessarily in veterinary medicine. Tonicity is defining fluids based off of their sodium concentration. Isotonic means that it has the same sodium concentration as what our extracellular space has. Hypotonic has a lower sodium concentration, and hypertonic has a higher sodium concentration. So tonicity is just describing the sodium concentration of the fluids. And then we talk about whether the fluids have a bicarb precursor. Our options for bicarb precursors are lactate, acetate, or gluconate. Some fluids have no bicarb precursors, some of them, and that would be considered an unbalanced crystalloid. Some of them have a bicarb precursor, and that makes it a balanced crystalloid. So this is a very nice chart. I think everyone should have a copy of this filed away somewhere, tucked into a book or something that you can always look at. There is a larger chart of this in the D. Bartola book about fluid therapy in veterinary patients, but this is very useful. So it breaks down all of the different types of fluids, and it tells you what their sodium concentration is, what all of their electrolyte concentration is, and you can compare it to your extracellular space. And so in that regard, it is something in which it can help to treat different disease processes based off of what you're trying to treat and what you want to try to avoid. So when we break it down, on the far left column is our plasma, so that's similar as our extracellular space. Then we start breaking it down. Our sodium chloride, the 0.9%, is what we most commonly use in unbalanced crystalloid form. So you can tell, interesting enough, that one has a higher sodium concentration. So it's around 154. So it's higher than our extracellular space, but it is still considered an isotonic fluid. When we talk about our lactated ringers, which is closer to the right side of this diagram, that is a little bit lower sodium than what our extracellular space has. It also breaks down what different type of bicarb precursors they all have, with lactated ringers having lactate, with ringers acetate having acetate. Our Normosaur R has acetate and gluconate as bicarb precursors, and our Normosaur M has acetate. On the far right side has a breakdown description of a maintenance fluid. So as you can tell, the sodium is very low, but the potassium is a lot higher than what our other fluids are. And that's because they're trying to make it a little bit closer to a patient that would be consuming these in their normal everyday life and don't have a deficit of them. So they're closer to our intracellular space, our maintenance fluids. We're going to talk a little bit more about why we would use those later, but just so everyone has an idea, this is always important. I think also if you only have a few of these types of fluids, it's important to just know what your hospital has. You don't need to have every type of fluid available. You just need to know what your hospital has and then be able to utilize it to the best that you can. So when we break it down further on crystalloids, we're going to talk about hypertonic saline. So hypertonic saline, again, has a higher sodium concentration than our body does. So that's going to cause fluid to go towards that higher sodium concentration. So it's going to cause fluids to leave our cells and go out into our extracellular space, that's going to, in some cases, potentially cause some cell shrinkage, and it's going to cause fluids to leave our cells. So there's reasons for that, and there's reasons we may really want that. So if we talk about a case in which we have intracranial hypertension or swelling in the brain, that's something that we want fluids to leave the cells and minimize that cell swelling. And in that case, that's something that we want to utilize this, and we're utilizing the cell shrinkage as a reason for using this fluid. In other cases, potentially this could cause harm. And so if we don't have cells that have a lot of backup or a lot of swelling, having fluid leave those cells could be potentially dangerous for the patient. So we want to utilize them for what they need, but don't utilize them if we don't need them. And isotonic essentially is going to cause pretty minimal fluid shift between inside and outside of the cell, and that's what we want in most cases. And lastly is hypotonic fluid. Hypotonic fluid has a lower sodium concentration than the rest of our body, and so that, again, based off of our fluid principles, that water is going to follow salt. It's going to cause fluid to go into the cells, which would have a higher sodium concentration than what our fluids do. And so that can cause cell swelling. And so that's one of the things that we want to make sure that, again, if we give a large amount of hypotonic fluids, that can cause fluid to rapidly rush into cells and cause them to burst and cause them to rupture. And so it can cause damage and can cause disease processes secondary to that. So in that case, that's something that we want to use it for a specific process, but we don't want to use it if we don't need it. At the bottom of my diagram, it describes an example of all of them, hypertonic saline being our hypertonic option, lactated ringers as our isotonic option, and D5W as our hypotonic option. So those are all examples of them. The next slide. All right. So when we further describe fluids, we're going to talk about different compositions of them. So balanced crystalloids would be our Normosaur R, our LRS, or our plasmolate, and that's because they have bicarb precursors. Our unbalanced would be our 0.9% sodium chloride because it has no bicarb precursor, so it's not going to help to normalize your pH as well as your balanced would. Your D5W, which does not have a normal electrolyte profile, it actually has no electrolytes in it. It has water and it has dextrose. And the other one that sometimes we colloquially will call things a half-strength saline. So that's going to have half the sodium and chloride concentration of your 0.9%, but it's also mixed with dextrose. So that's why we call it half-strength saline. And that does not have a bicarb precursor, but it's also not balanced. The next slide that we're going to talk about is talking about different types of bicarb precursors. So again, lactated ringers has lactate. Normosaur R and acid and plasmolate have acetate, and Normosaur R also has gluconate, so it has acetate and gluconate. The lack of bicarb precursors is, again, our sodium chloride, our D5W, and our half-strength saline. Sometimes we avoid lactate fluids in particular cases, and so we're going to talk about some reasons why potentially some clinicians will steer towards using a Normosil R or a Plasmolite as opposed to lactated ringers. I think, honestly, it depends on what your hospital's availability is. If you have the option between both of them, then potentially you could choose between one or the other. If your hospital is only able to get one of them, then I would use them equivocally. But it is something, especially with COVID, we've had a lot of back orders and it has been difficult to get some types of fluids. And so I would look to see what your hospital has and become familiar with it and then use that as what it is. So your crystalloids. So we're going to talk about what is the reason to give them. So in general, our replacement fluids resemble, again, the composition of our extracellular fluid space, which is a little bit higher in sodium and a lower in potassium. Our maintenance fluids are a little bit lower in sodium and a little bit higher in potassium. So we want to talk about what our purpose of fluids are. So when you look at a patient, and when I teach interns and residents about fluid therapy, I talk about it as if it's a medication. We would never not give a dose for a medication that we would want to give to one of our patients. And so fluids is exactly the same. We have to look at fluids as if it's a medication, and we have a dose of a medication, and then we have a frequency of the medication, and we also have reasons to stop a medication. So we need to look at fluids as if it's a medication, and then we need to look at them for why we would give them. So the same as you would think very thoughtfully about if an animal needed an antibiotic or didn't need an antibiotic, and what antibiotic you would choose and why you wouldn't choose an antibiotic. Those are all the same as a decision you need to make about fluids, just for a different reason. So we need to look and see if a patient is hydrated, if it's hypovolemic, and what electrolyte disturbances are present. So sometimes that can be a little bit difficult, especially when you're very new being a veterinarian, determining the difference between dehydration, hypovolemia, and can you have both together? And the answer is yes. So a patient that is dehydrated is going to have some of the classic markers of being dehydrated. So we're looking at a prolonged skin tint. We're looking at potentially dry mucous membrane, sunken eyes, like poor elasticity to the skin. And if we're looking at blood work, we're looking at an elevated total protein concentration. All of those are an elevated hematocrit, potentially. All of those could be signs that a patient is dehydrated. Also, a patient's history could tell you that they're dehydrated. So if we have a patient that has been vomiting for a few days and not really holding down food or water, then they're going to be dehydrated because they're not keeping anything in their system. If we know that a patient has underlying diabetes or kidney disease, all of those gives us reasons why we know that they have an underlying reason to be dehydrated. So we know potentially, even based off of a history before we do our physical exam, that we may expect a patient to be dehydrated. So that is a reason for us to look and see if they're hydrated. Lastly, we're going to talk about is a patient hypovolemic. So hypovolemic is a little bit different than dehydration. So hypovolemia talks about our volume status in our body. So if a patient comes in as a trauma patient that has just been hit by a car, they probably are not dehydrated, but they probably are hypovolemic if they have any bleeding internally, if they probably are hypovolemic, and they potentially are shocky. And so that patient may have just a volume deficit, but isn't dehydrated. The classic example of a patient that is both is our diabetic ketoacidosis patient that comes in that's been sick for a few days and vomiting and not keeping food down. So they have lost a lot of volume and a lot of fluids, but they are also dehydrated, and their body doesn't have a great way to stay hydrated due to its osmotic diuresis of how high its glucose is. So in that case, we're talking about a patient that's hypovolemic, dehydrated as a combination. Other patients are potentially just dehydrated, and I think the classic example of that is a fairly healthy young patient that comes in for a few episodes of vomiting. And in that case, they are probably not hypovolemic. They probably haven't gotten sick enough to become hypovolemic, but they maybe are dehydrated just because they have some fluid loss. So in that case, it's more of a classic just dehydration and less of a situation of being hypovolemic. The other question is what electrolyte disturbances are present. So depending on what your patient's electrolytes look like, that may tell you how you differently want to be able to treat them versus not treat them. And so in that case, it's a situation which looking at your blood work may give you a little bit better idea of how you want to treat them or not treat them. The other questions that we have is talking about whether we want a maintenance or a replacement fluid, and we've touched base a little bit on this previously. To be honest with you, maintenance fluids are not common in veterinary medicine. I don't carry any maintenance fluids in the hospital that I have, or the hospital I work for. I don't own it. The hospital that I work for. In that case, because it is a situation, maintenance fluids are more associated with long-term human health care in patients that have hospice care, or patients that are not actively eating and drinking on their own, but don't have a large volume of losses. And so maintenance fluids are more for patients that are hospitalized for long-term, that are not keeping up with their electrolyte and their fluid intake. We don't have those in veterinary medicine. We don't have long-term patients that just live in our hospitals that aren't eating or drinking for various reasons. But that is a situation where using Normasol M isn't necessarily something that we would commonly reach for. And so more commonly, we would just need a replacement fluid. So we're going to have a little bit of an intellectual nerd moment here. So your complete classifications of your fluids, you can impress people in your clinic by telling them, is that a lactated Ringer's is an isotonic buffering crystalloid that has balanced and replacement fluid benefits. The Normasol M is an isotonic buffering crystalloid that has a balanced maintenance fluid requirements. Sodium chloride is unbalanced isotonic and non-buffering. D5W is unbalanced hypotonic and non-buffering, and our hypertonic saline, or 7.5 sodium chloride, is an unbalanced hypertonic non-buffering crystalloid. So when we talk again about medications and we talk about what are pros and cons of them, we have to know what's going on with them, and we have to know why we prescribe certain medications, and then we want to know what our potential risks are associated with them. That helps us be able to look for them. That helps us teach our team how to look for them. That also gives us an idea of what to talk to owners about, to set up expectations and to set up what they should be aware of. So by far the number one concern with fluid therapy is volume overload. Volume overload can happen in many ways, and they can look in different ways in different patients. So volume overload is something that we see commonly in our clinic for the fact that we run a hemodialysis program out of our clinic. So we see a lot of patients that come in very severe renal failure, that come in for dialysis. In those states, when they come in, they're often very, very fluid overloaded because their kidneys are no longer processing it as it should, and it starts to back up into their system. So things we're watching for in volume overload is they're looking for signs of third spacing, or we're looking for signs that they're storing fluid when they should not be storing fluid. So that can be things like edema in their legs. That can be serous nasal discharge they will sometimes have. That can be when their conjunctiva gets very thick and swollen, that they're starting to third space fluid. Cats love to become volume overloaded. You could look at a cat wrong and they can become volume overloaded. And so cats are specifically something that we have to be very cautious with fluid therapy. Some cats are specifically, it's these very obese, large cats that come in and that their body does not handle fluids well. So you have to be very cautious. You have to base their fluids based off of a lean body weight, and really, really watch them and really, really monitor them for the fact that they can become fluid overloaded very quickly. Cats, when they get fluid overloaded, they don't tend to get the edema down their legs like dogs do. They don't tend to get the swollen faces like dogs do. It goes right to their lungs. So they will get congested. They will get pulmonary edema. Sometimes they'll get pleural effusion. Sometimes they can get ascites. All of these are signs that we can see in cats when they become fluid overloaded. So we want to make sure that that's always on our radar and something we're looking for. And so with patients that are hospitalized and getting fluids, we always monitor their weight. And so we monitor trends. If you slowly are seeing a cat just slowly tick up fluid after fluid after fluid after it's just ticking up on its weight when it's in your hospital, it's probably not just eating and getting better. You potentially are leading it down a road of becoming fluid overloaded. So that's something you really want to watch for, and you really need to watch and monitor closely for. Dilutional coagulopathies are something that we can see with crystalloids, and the reason why is because if we give them large volumes of crystalloids to replace fluid deficits, we're diluting out their clotting factor. So we normally say that a patient is at risk for developing a dilutional coagulopathy if we replace over their blood volume in a 24-hour time period. So we commonly will see this in patients that are shocky, where we give large volumes of fluid boluses, or in dogs that have things like a hemoperitoneum or a hemoabdomen that bleed a lot, and we replace it with fluids and crystalloids to try to be able to get them stable to go to surgery. In those cases, they are using a lot of their clotting factors because they're bleeding and they're trying to preserve their own bodies, but we're also replacing a large volume of fluid and potentially even blood products that do not have clotting factors. So in this case, it's something that we cause them potentially to have a bleeding abnormality secondary to giving them fluids that do not have clotting factors. So if you are giving a patient crystalloids that exceeds its blood volume, it's always important to check clotting factors and clotting times. And in those cases, you may need to add plasma to your routine, just for the fact that then you would be providing them with clotting factors. Hypotension, it seems weird because we commonly give fluids to treat hypotension. So why would fluids cause hypotension? The main one is that lactated ringers can cause histamine release if bolused. It's seen very rarely, but it is documented. So in that case, it's potentially something that we could cause a histamine release in some cases, which could cause a very transient hypotension. So if you have a patient that potentially has a mast cell tumor degranulation and is in systemic shock because of its mast cell tumor degranulation, maybe lactated ringers isn't the fluid you would choose to bolus them, and maybe you would choose Normasol R or Plasma-Lyte to bolus them to try to potentially minimize that histamine stimulation. But it's something, if you see it, and it's a paradoxical hypotension when you would expect for their blood pressure to be getting better, then potentially it could be secondary to a histamine release. Lastly is electrolyte derangement. So if you give a patient a fluid that has a very low sodium, you are going to make them have a low sodium, which could potentially cause them to have, again, cell swelling and cell death. So it's something that we want to make sure that we're targeting the right electrolyte profile for the fluids that we want to be able to make sure that we're not causing harm when we're giving fluids, and that we want to choose the best thing for them. Crystalloids can also have inflammatory reactions on the body. So there are a few pro-inflammatory reasons that fluids can cause. So we talked about cell swelling and bursting. So if you give fluids that cause cells to swell and burst, that causes lots of inflammation in our body, and our body hates it. It also can cause increased endothelial injury when you're giving boluses or high fluid rates. It can strip that glycomatrix right off of our endothelium, which causes inflammation. It may not clinically cause a problem in your patient, but it is something that could potentially contribute to its inflammatory state that it's in. Also, lactated ringers has been targeted as more of an inflammatory fluid, secondary to the fact that it causes neutrophil activation, and then it causes CD18 adhesion molecule expression, which both of these are pro-inflammatory mediators. It's mainly in the lactated ringers that has the D-lactate formula, which is not the predominant lactate in our lactated ringers. So in that case, it is something that we don't commonly see it, but it is something to put on your radar and for you to look at. And so potentially if you have a patient that is in a very severe systemic inflammatory condition or is very what we would call SIRSy in the critical care world, it's something that maybe you don't reach for lactated ringers, and maybe you reach for Normasol R, which maybe is slightly less pro-inflammatory. If you only have lactated ringers, you're reaching for lactated ringers. But again, it's something, if you have a hospital that has all of these different fluids for you to choose from, you can sort of shop and pick what you want. There are also crystalloids that has anti-inflammatory properties, mainly being hypertonic saline. And so that causes impaired neutrophil chemotaxis and activation. It also causes decreased damage to our extracellular matrix. So it may be something in some of these cases where we have a patient that has that's hypotensive and hypovolemic, secondary to things like a septic abdomen, it may be something that we want to give them a single solitary hypertonic bolus to try to help get their blood pressure up, but also it maybe provide a small amount of an anti-inflammatory component with our fluid therapy. So next we're going to talk about colloids. So colloids in themselves are very controversial, and we're going to talk about lots of controversies with colloids. But you can't talk about fluid therapy and not talk about colloids and talk about why we don't use them, why we do use them, and what you need to know about them. So colloids is a solution that contains a large molecular weight molecule that exerts an intravascular colloid oncotic pressure. It's a very big phrase for basically saying that these fluids have very large molecular molecules in them that cause a vascular pull to pull fluid into the intravascular space and hold it there for longer than what it would normally be with just doing crystalloids. So in that case, we can talk about synthetic and natural colloids. So our natural colloid is plasma. That's our only natural colloid that we have. And so our natural colloid is plasma. Albumin is the large molecular weight molecule that's in our natural plasma. Its colloid oncotic pressure is the same as what our plasma is. So it's 17 to 20. It does have bicarb precursors because it's our plasma. But it's, in all honesty, when we compare it to synthetic colloids, it's a very poor source of colloid oncotic pressure. So if you have a patient that truly needs a colloid, giving them plasma is potentially not going to give you what you're looking for and is potentially not going to be that helpful. We do now have albumin products in the US. I'm not exactly sure which ones you guys have in India, but we do have both human albumin and we also have canine albumin. In those cases, they are very good sources of colloid oncotic pressure for the fact that we're just giving large quantities of albumin. There are pros and cons associated with that, but it is something that if we are truly giving plasma for its colloid oncotic pressure, it's something that using plasma is not going to be that helpful. We use plasma for other things. We use plasma for their clotting factors. That's by far the most reason. That's the number one reason why we give plasma transfusions to patients. We also use it for things now like therapeutic plasma exchange and exchanging plasma with their plasma that potentially has a toxin in it and interfusing new plasma in it. But it's not great at trying to help a patient who needs to increase their colloid oncotic pressure. Synthetic colloids are amazing at it. And that's why they were made. And that's why we're going to talk about them and why we don't use them that much anymore and what the complications of them are. But we're also going to talk about why they were made and why they exist in the world. So there's 4 types of synthetic colloids. There's gelatins, there's hydroxyl ethyl starches, there's dextrans, and there's a hemoglobin-based oxygen carrying capacity fluid that isn't really on the market anymore, but technically is a colloid. So we're going to talk about it. Gelatins, one type of synthetic colloid, is formed by degradation of bovine collagen. The advantages to gelatin is that it has a very low molecular weight, it's minimally antigenic, and it has a limited impact on clotting times. Its plasma half-life is about 2 to 4 hours, and it's excreted in their urine. So there's multiple types of gelatins. There's oxypolygelatin or vetaplasma. So you can see if we compare it to what our colloid oncotic pressure of plasma was, which was about 17 to 20. Now we're increasing our colloid oncotic pressure that this fluid exerts to about 45 to 47. But it does have a low molecular weight, so it's similar in molecular weights to our albumin. It's available in the US. Succinylated gelatin or gelofusine is only available in the UK. And ureolate gelatin or Hemosil is only available in the UK to my knowledge. And so in that case, that's why we're using them, is we're using them for the fact that their large molecular weight are these gelatin molecules. Dextran. So dextrans is a linear polysaccharide that's produced by leuconostatic bacteria. It has a much bigger colloid oncotic pressure, and it also has a much larger molecular weight. So the dextran 70, the 70 at the end of it is based off of what the molecular weight of the molecule is. So these molecules are big. The gelatins, as we just said, only had a molecular weight of 30. So in that case, it's something that it's double, more than double what the gelatins are. And so those are what's causing that fluid to shift into our intracellular space, and to stay there are these large molecules. By far the most common type of colloid, and the one I have the most experience with, is our hydroxyl ethyl starches. These are a synthetic polymer of glucose called amylopectin. They're divided based off of their chemical description. So C2 to C6 is that it has a higher substitution that leads to a slower degradation of the hydroxyl ethyl starches at the 2, 3, and 6 position. So you want your hydroxyl ethyl starches to have a high C2 to C6 ratio. Molecular substitution is the amount of the hydroxyl ethyl starches per group of glucose. And so in that case, when we look at this chart and we break it down, their molecular weights are much larger than the other ones we talked about. So if we look back and we say, okay, our dextrans had a colloid oncotic pressure of like 59, and we look and say that our head of starch 264 has a colloid oncotic pressure of roughly about that same amount. Some of the other ones are a little bit closer to albumin, but their molecular weights are much larger. So when we break down head of starches, we break them down into two categories. So we break them down into ones that have very, very large molecular weights. So big molecules. So that's the head of starch 670. It has a molecular weight of 670 kilodaltons. And if we compare that again to our gelatins that had a one of 30, they're huge. They're huge molecules. And so therefore, they're banking on that huge molecule taking a long time to break down, and so therefore staying in the intravascular space for a long time period. So the head of starch 670s use a big molecular weight molecule, but a low C2 to C6 ratio. So there's less substitution, so maybe that would break down a little quicker, but the molecules are so large that they stay in the vessel for a long time period. The first veterinary approved colloid is the vet starch, which is at the bottom of this chart. So that has a little bit of a different theory with head of starch. And so that is a small molecule, 130 kilodaltons, but a really high C2 to C6 ratio. So lots of little tiny molecules, but the substitution makes them very difficult to break down. So there's tons of little molecules that are staying in the system, but the substitution of it makes it harder for us to be able to break this down. So that is sort of the caveat to which head of starch you buy and which head of starch you save in your clinic. And you may have no head of starch in your clinic. Your clinic may be one that doesn't use colloids at all. You may use colloids, and so you should know if you're using ones that have a high molecular weight, low substitution, or a low molecular weight and a high substitution. And it honestly may just be what you can buy and what's available. So we could have an entire lecture on colloids and why they're bad and why we don't use them. But that's not what our lecture's on today, but we are going to touch base about it. So colloids have become very much out of favor in the past 10 years. There are specific areas, specifically in the EU, that banned them from all use in human medicine. We're not quite there in veterinary medicine, but we're following their trends, and that it is not something that is used as commonly as it used to. We used to give tons of animals head of starch. Everyone got head of starch. Low blood pressure, you got head of starch. Everyone got head of starch. And that's not what we're doing now. That's not what the current trend is. We still, in my clinic, have head of starch. It's used very infrequently, like maybe once a month, maybe. It's not used commonly. And that we have reached to other things to use, and we've reached to other ways to treat our patients, just for the fact that we understand what's going on in human medicine with colloids, and we understand what they're doing to people, and that we don't have that evidence yet to say it's happening in animals, but we don't have evidence to say it's not happening in animals. So the adverse effects that you can see with colloid therapy is that we can see coagulopathies that are not associated with dilutional. So a different type of bleeding disorder that is not similar as what we saw in crystalloids. In people, it's renal failure. 100% colloids have been linked with increasing the risk of renal failure and increasing mortality in human patients, and that's why it's not encouraged to use. Liver failure has been associated with it. We can see allergic reactions. Like, oddly, the allergic reactions are more commonly associated with the gelatins because it's like a bovine collagen cross situation. And lastly, we can see overhydration again with them. We can see fluid overload because we're giving them these huge molecules that are making fluid rush into our vessels and stay in our vessels for longer. And so it's more that the heart is being exposed to. And so specifically, cats love to go into fluid therapy overload. So it is something that we can see specifically with colloids. And again, we have to be really careful with that. So the colloid-associated coagulopathy is different than the dilutional coagulopathy we saw in the crystalloids, and it's secondary to a decreased expression of our alpha-2 b beta-3 on our platelets, and that we have a decreased activity of certain procoagulants, particularly our von Willebrand factor and our factor VIII. Lastly, to just touch briefly on the last colloid that we talked about, and that's our hemoglobin-based oxygen-carrying colloid, that's oxyglobin. Oxyglobin is not in production in the US, which makes us really, really sad. They also, to my understanding, have not been able to get it in the UK for some time period. We desperately would love to have it back, but it's an ultra-pure glutaraldehyde polymerized hemoglobin bovine mixed with LRS. It's an oxygen-carrying molecule that doesn't involve them needing a blood product. And so this works amazing for cats that have, so we have a B blood cat and we are out of B blood in the hospital, you could give them oxyglobin. If you have a dog that has IMHA and is severely reacting to all of the transfusions you're giving it, and the people aren't ready to commit to doing IVIG, or they're not ready to commit to doing a dialysis therapy, it's something in that regard that we would love to be able to give them hemoglobin, because we can give them the oxygen that they need, that their red blood cells aren't giving them, but that we don't need to worry about the antigenic reactions of giving blood transfusions. But it does have very large molecular weights, and it does provide a small amount of colloid oncotic pressure. So it does act as a colloid, although we commonly more use it as a blood alternative. It is not in manufacturing right now. If you have it in India, I'm very, very jealous of you guys. So now we're going to talk about dosing and how to prescribe fluids for a patient. So blood volume, for cats, a blood volume is about 50 to 60 mils per kg. Again, if you have a severely overweight, heavy cat, base it off of a lean body weight. Don't base it off of the 25-pound or the 15-kilogram cat who should weigh 10 kilograms. Base it off of the 10 kilograms. And then juveniles have a much larger body surface area, so they have a larger blood volume. And so kittens have closer to 75 mils per kg, and puppies have 90 mils per kg. So the maintenance fluid requirements. So maintenance fluid requirements are what we're looking to maintain a patient that's not hypovolemic, not dehydrated. We've restored their losses, but they're still maybe just not eating in our hospital. So in those cases, we're looking at about, for an adult patient, we're looking somewhere between 40 to 60 mils per kg per day. Cats lower on the realm of closer to that 40 to 50, dogs higher of 50 to 60. Again, same as when we prescribe medication. Look at your patient, look at what's going on with your patient, and make a choice. If your patient has severe underlying heart disease, but is in the hospital because it has vomiting and it's not eating, it needs fluids, but its heart's not going to be super thrilled with you. And so you have to be cautious. Should you put that patient on the high end of this range? Maybe not. Maybe you wouldn't even put it on the low end of this range. Maybe you would start maybe at 3/4 what it would be, just to try to be as cautious as possible about what's going on with its heart. So I never tell people to just look exactly at what this note says and write it down on a sheet of paper and never look back at what's going on. You need to look at your patient and you need to know what's going on. If your patient has a heart murmur, You need to talk to the owners about a higher risk of fluid overload, but you also need to look at your patient and say, maybe I won't be very aggressive with fluids. Maybe I'll try to be a little bit less aggressive with fluids, and maybe it'll take a little bit longer for us to rehydrate them, but I'm being a little bit safer for them. And for our pediatric patients, we're looking at 90 mils per kg per day. So we're going to talk about shock therapy. So shock therapy is something that scares people, but I think it's something very useful. A patient can come into shock in any hospital, whether you work in a critical care hospital or whether you're seeing emergency or you're a general practitioner in your hospital and someone walks in the door. Something's going to come in one day and it's going to be in shock, and you're going to need to figure out what you need to do to save that patient. So to determine the type of shock, you're looking at the 4 types of shock. So cardiac. So cardiac means that they are in shock because their heart is no longer functioning appropriately. So in that case, that's what we're looking at, that patient that comes in that's cyanotic, muddy, has crackles, trouble breathing. So in that situation, this patient is in shock but should not receive fluids. This is a patient that us giving it fluids could make it substantially worse and could potentially ultimately lead to a progression of its passing away. Distributive shock, the classic example of that is a patient that has septic peritonitis that comes in that's septic. In this case, all of their blood vessels do not have appropriate vascular resistance, so everything's just pooling in their periphery. Their skin's red, their pulses are poor, nothing is working well for them. And so even if you're giving them fluids, it's all just sitting in their vasculature. It's not flowing well. And so that is something that we call distributive shock. Hypovolemic shock is the previously healthy young dog. It gets hit by a car. It has a hemoabdomen. It comes in. It's hypovolemic because it's lost blood into its abdomen, and that we know why it has lost blood into its abdomen, and that it's essentially hypovolemic because of a very acute and sudden loss of fluid. And obstructive, the classic examples of obstructive shock are our gastric dilatation volvulus patients and our pericardial fusion dogs that are in tamponade. Those are the classic examples. So besides cardiac, the other 3 types of shock should be treated with fluids. You may have to adjust what fluids you're going to choose, but all of those should be treated with fluids, with cardiac being not something that you would treat with fluids. And then lastly, when you're looking at a patient that has shock, is it also dehydrated? So shock, we usually talk more about a hypovolemic state, but again, you can have a patient that is in hypovolemic shock that's also dehydrated, and that's the situation in which the animal's been vomiting for days and days and days and now has lost enough fluid that it's hypovolemic, but it's also very much dehydrated because it's exhausted its resources. So for a hypovolemic patient, you're looking at initially starting with a bolus therapy. So bolus therapy is useful because we're trying to help them get out of the immediate crisis, and we don't have 24 to 48 hours to pull a patient out of hypovolemic shock. We have, in some of these cases, maybe an hour, maybe even less than an hour, but it's not something where you can give little teeny tiny amounts and put them on a pump and see where you're at. It's something that you have to be fairly aggressive in what you're doing, and that you need to start conservatively, reevaluate, and see how much more aggressive you need to do. So again, if you think in your mind, what I'm talking about is that patient that comes in that's previously healthy, it has gotten hit by a car, it's lost a decent amount of blood into its abdomen from an internal injury, and that it comes in, it's not walking, it's mentally dull, quiet, its gums are that light pink, pale color that's not amazing, its feet are cold, it's maybe got some lacerations going on, and your tech keeps telling you that they can't get a blood pressure, they're working on catheters. Like, that is the patient that we're talking about in this situation. So when they get an IV catheter in, you're looking at starting to try to bolus them. And so you can choose to start, normally, most people will start with an isotonic crystalloid bolus. And so that's going to be somewhere for dogs about 10 to 20 mils per kg over 5 to 10 minutes. Cats, again, cats hate fluids. Cats love to get fluid overloaded. So start a little bit more conservatively. Cats can get hit by cars. Cats can get a hemoabdomen from being hit by a car. And so start a little bit more conservatively, about 5 to 10 mils per kg over 5 to 10 minutes. If you're going to start with hypertonic saline, you're looking at about 3 to 5 mils per kg over 5 to 10 minutes, and then you want to reassess. And so you want to look and say, okay, I've given one isotonic bolus, one hypertonic bolus, my blood pressure was unreadable, and now my blood pressure is 80. You're doing great. You're cooking with gas. You're doing great for this patient. If you look at it and you've only given one isotonic bolus and your blood pressure went from unreadable to 60, we got to keep going. We got to keep looking at this patient, and we got to make the next steps for this patient. In some cases, if we're not getting anywhere with our hypertonic, our crystalloid, and that patient is still hypotensive, still looking like it may leave us in a short time period, doing a colloid would be something that we would reach for, because it isn't something that we're giving long-term large volumes in a CRI over multiple days. And it's a situation in which in some of these animals, it is a life or death situation. And so we're choosing somewhere between 3 to 5 mils per kg over 5 minutes. This has fallen, again, a little bit out of favor, but some people will talk about it, is giving them a turbo starch bolus, which is hypertonic saline and head of starch mixed in one syringe and given to them. They sometimes really like it if they aren't doing well. So that is what we would do in a patient that was shocky. Now we're going to talk about a patient that's dehydrated. So you need to figure out how dehydrated they are. So you're looking at what your percentage dehydration is. So we've all seen the chart that's in our vet school book that says if it's less than 5% dehydration, we can't really detect it on our physical exam. What is, what is 5 to 7% dehydrated? What's 7 to 10? What's greater than 10? So determine your percentage dehydration, calculate what your maintenance fluid rate is. So again, that's the 40 to 60 based off of a dog or cat and lean or chubby body weight. Then calculate your percent dehydration. So take that percentage times your kilograms. That's your fluid deficit in liters. So then you want to replace that over 24 to 48 hours in addition to what your maintenance is. So if your dog is 2 liters behind in its dehydration, then that 2 liters is divided out over 24 to 48 hours in addition to that 40 to 60 mil per kg per day of the maintenance fluid rate. And some of it depends on how sick those patients have been. If they've been sick and dehydrated for days leading up to this, you don't need to correct it in 24 hours. Correct it in 48 hours. They didn't get here in one day. They're not going to get out of this in one day. Give them a little bit of time, and that it is a situation which some of them, again, also have underlying comorbidities, which may make it harder for them to be able to tolerate fluid therapy. So in this case, it is something that sometimes you have to go a little bit slower. And slow and steady wins the race, as opposed to trying to fix everything instantaneously. This is maybe a little bit small, there are a link to it to tell you where you can go to get this. This diagram is from the New England Journal of Medicine. It's a little bit old. It's, I think, 2008, but it talks about goal direction in fluid therapy. So it talks about trying to create a goal in your mind, what you want for that patient. And when you achieve it, sort of backing down and de-escalating your fluid therapy and not trying to blow it out of the water. And so we talk sometimes about this with patients that come in that have a hemoabdomen or a hemoperitoneum. This is the best way that I have to describe this. And this is a situation in which we don't want their blood pressure to go from non-existent to 160 with you blasting fluids, for the fact that you could potentially exacerbate that blood clot that they've tried to create and blow the blood clot off of their bleeding mass in their abdomen. And now they're having bleeding again because you've caused hypertension now. So we want to try to do closer to what we call permissible hypotension, where we want to steadily improve it. We want to go from that non-readable blood pressure to 60 to 80 to 90 to 100, and then try to ride it from there. We don't want to go from 0 to 150, which is blasting away fluids, for the fact that maybe they don't need that much. And it has been shown in human medicine that giving them large volumes causes exacerbation of them being fluid overloaded and causes more mortality. And so if you have a human patient who obviously sometimes has multiple comorbidities, give them a large volume of fluids and then you fluid overload them and they ended up on the ventilator, you're substantially worsening their chances of leaving the hospital. And so in these cases, we really do have to work on being conservative with our fluids, giving them what they need, but not more than what they need. So the ways that they use in human medicine to determine goals and end direction is looking at what our response to fluid is the central venous pressure. Are we seeing a response to it with our fluid therapy and de-escalating once we've reached an ideal central venous pressure and restarting if it drops? Talking about pulse pressure variations, cardiac output monitoring, which is something they love to do in human medicine. We don't do it commonly in veterinary medicine. Monitoring acid, base, and lactate trends, and lastly, microcirculatory imaging are all things that can be used specifically in human medicine, also in veterinary medicine, to look and see if you're getting close to what your endpoints are. So when we look at our central venous pressure is the pressure in the pressure of the blood in the thoracic vena cava or the right atrium. It reflects how much blood the heart has coming into it, or the preload. It reflects what the body sees as it's coming in. So in patients that have hypovolemic shock and have lost a large volume of blood into their abdomen from bleeding, they've got a really low preload. The heart feels like nothing's coming into it. There's nothing to pump out. So in that case, their central venous pressure is very low. So as we're giving them fluids, there's more and more preload coming in, and there's more and more being presented to the heart. And so in that case, if we are starting to get close to what's normal, we probably don't need to keep giving them more fluids. Maybe they have all the volume they need, but their vasculature is not working well. And so in those cases, instead of just continually giving them fluid boluses, sometimes we end up having to talk about adding on vasopressors, norepinephrine, dobutamine, those things sooner than maybe what we previously used to, because previously we used to just give them boluses and boluses and boluses and hope it all worked out for us. But in this case, it's saying, what if we look at numbers? What if we say we reached the blood volume and we've restored everything they've lost and their blood pressure is still low? Then we probably don't need to keep giving them more and more fluids. Maybe we take that fluids that we've given them and we try to help their vascular act more normal or improve vascular tone to try to help with that. People in human medicine, they love central venous pressure monitoring. So in central venous pressure monitoring, you do need to have a catheter in place. It's a jugular catheter. It goes down to the level of the right atrium, and then you hook it up to a pressure transducer, and you get these lovely graphs that always look exactly the same as this. They don't. So on the top, there's an ECG tracing. On the bottom, there's the jugular tracing. The A is your atrial contraction. C is your tricuspid valve into your right atrium during ventricular contraction. X is the downward movement of your ventricle during systolic contraction. B is the blood filling in the right atrium against a closed tricuspid valve. And Y is the tricuspid valve opening in diastole. So it just shows you the different stages of the heart cycle. But it helps because we can tell what normal is, whether we still need to give more fluids or whether we've now fluid overloaded them. In people, they do cardiac output monitoring. So cardiac output monitoring, ways that they do that is with things like thermodilution. So they have a jugular catheter and they have a femoral artery catheter. They give a certain temperature of a medication, and then they measure what temperature it is at a different catheter, and that gives them an idea of transit time, and it gives an idea of how well your vasculature is working and moving blood along. We don't commonly use that in veterinary medicine. Lithium dilution is the same concept. You basically look at a starting concentration and an ending concentration and how well it's distributed throughout the body. And in people, they talk about transesophageal echocardiogram to try to measure that preload. We don't use it commonly in veterinary medicine, but it's something to put on your back radar. This we use all the time. Love it. Love it. Being a criticalist, we love it. So lactate clearance is essentially looking at what a patient's lactate is when it comes in. So that hemoabdomen that just got hit by a car, their lactate's going to be high. Their lactate's in the 10s when it comes in. And maybe after some fluid boluses, you get another blood gas for you to look at, and their lactate is now 5. This is great. We're doing great. We're helping and we're improving perfusion and we're improving anaerobic metabolism. So looking at what lactate clearance is, which is essentially just looking at what our volume is and seeing what our lactate is improving with fluid therapy. Looking at trying to get a better pH. So is our pH normalizing? Are we getting that patient closer to normal? And then also, is our base deficit leaving? Like, are we making goals towards getting this patient as close to normal as we can? That's what we use in veterinary medicine. We don't use all these other things, but this is very easy for us to do. And the other thing is looking at a patient, continuously looking at them. And that's looking at them. So everything is fluid in veterinary medicine. So we don't just prescribe something and then never look back, and we never go back and say, oh, is it working or is it not working? We have to look at it and say, oh, he's so much brighter than he was previously. Oh, he's up and walking. He wasn't previously walking. All of these things are very useful for us. So then we have to talk about endpoints of resuscitation. Again, is their lactate better? Is their pH better? Is their electrolytes better? Looking and seeing, were they coming in and their kidney values were very elevated and now they're better? Was it a pre-renal component to it, and now we're fixing that dehydration? And lastly, their nutritional intake. So their nutritional intake is something that we look and say, that's fluid coming into their system. So do we now need to cut back on their fluids because now they're eating and drinking? Or are we giving them now enteral diets to help them? And lastly, are they eating on their own? That's the end goal of all of this, is that if we start to see a patient that previously wasn't eating and now starts eating, we're probably doing really, really well with what we meant to be doing. So we're going to go through a little bit of some case studies. I don't know exactly how many we're going to get through, but we're going to go through as many as we can here. So first, we're going to talk about Maverick. So Maverick is a 4-year-old male castrated domestic shorthair. He came in for 24 hours of straining to urinate, and he had started vomiting prior to presentation. When he came in, his temperature was 96.4 Fahrenheit. His heart rate was 150. And his respiratory rate was 36. He came in flat out, laterally recumbent. On his ECG, he had absent P waves and tall tented T waves. And in the left-hand side of the screen is a venous blood gas for you guys to be able to look at. So the top part of the venous blood gas tells us what his PCV and his total solids are, and then it breaks down what his pH is, his hematocrit, his electrolytes, his lactate, his glucose. We use a Siemens machine, and so that's a printout of our Siemens machine. So you guys can all look at it. You can mentally put in your head. I think all of you guys have an idea of what is going on with Maverick, but you can look at the ECG and you can look at the blood gas and look to see what the abnormalities are. And then we're going to talk about maybe some fluid therapy options that you would choose for him. So what initial interventions can be used to address these acid-base abnormalities? So on his blood gas, he's got very, very severe hyperkalemia. That's his number one problem we have to focus our interventions on, is a severe metabolic acidosis, hyponatremia, and hypokalemia. Those are his initial problems. So when this cat comes in and you have your team with you, you have to talk to them and you have to tell them what to do and what your concerns are and what you need to do to help this cat. This cat is not stable. This cat cannot wait an hour for you to look at a book and figure out what you need to do for him. You need to work with him right now. So when we look at this, the number one concern is obviously the hyperkalemia. That's what's causing his ECG abnormalities, and that's one of the first things we have to address. So working with your team to assess that this cat is sick and that we need to work aggressively to help him is very important, and time is of the essence for this cat. So in this case, we're talking to your team about getting an IV catheter in, getting this blood work for you right away, getting everything put together, getting ECGs on him, getting temperature, getting heat support. All of these things are helpful for people to start doing while you are figuring out what medications you need to give this cat. So what are our options for hyperkalemia? So our options to treat hyperkalemia is albuterol. It's a beta-2, inhaled beta-2 agonist. It pushes potassium intracellularly out of our extracellular space. Our calcium gluconate is a cardiomyocyte protectant. It increases our cardiac myocyte threshold. So it doesn't change what our potassium concentration is, but it makes the heart feel better and makes the heart think that our potassium concentration is lower than what it is. Insulin and dextrose, which moves potassium inwards again. And lastly would be sodium bicarb as a treatment for hyperkalemia, but we do not commonly reach for it in cases such as this where we have a way to treat it without needing to use sodium bicarb. So what fluid therapy options do you have? What do you want to do to help Maverick? In your mind, what are you telling your team to go get for you? So for him, we're looking at, are you going to choose crystalloid? Do you want colloid? Probably not. This cat doesn't seem like he's a candidate that would need to have colloids. This cat needs crystalloid fluids. And would you want to give him a fluid that has potassium? That's always something that's debated at all of the critical care conferences. And honestly, it's a situation in which there has been studies, most recently the one out of UPenn, where they studied urinary obstruction cats that had very high potassiums. And in this case, it is something in which they gave them fluids that did not have potassium and did have potassium to try to help in the initial stabilization. And the cats that received fluids that were balanced, that had potassium, so things Normosil R, lactated ringers, had a better long-term outcome and a better mortality, had a higher discharge rate from the hospital because they had a quicker resolution of a normal pH due to the bicarb precursors, but they did not think that the potassium in the fluids affected their long-term prognosis. So on the right is his venous blood gas. That is essentially about an hour after he's come in the hospital. He got calcium gluconate, he got insulin dextrose, he got unblocked, and about an hour later, his potassium is down from 8.9, which it was on his initial one, to 5.6. And so we're working with him. We're making him a better, happier cat, and we're getting him more and more stable. So at this point, you can now get him moved into ICU, get him set up on more aggressive replacement fluids, but that you potentially don't need to have him out on the table with ECG monitoring further. I don't know exactly. We're probably getting very close to being right around the time for stopping. But the other cases we have is talking about a dog that has also hyperkalemia, but a little bit different ways to treat it. And so I'm sure that these slides will all be shared with you guys, but this is about Maximus. It's a 7-year-old Doberman that presented with intermittent GI signs. He's had pretty significant weight loss, and he previously had an episode of vomiting and diarrhea. He was seen at a different ER clinic, and no blood work was performed previously on that. He presented laterally recumbent. His temperature was low. He was tachycardic for a big guy like a Doberman that presented to the hospital, and his blood pressure was unable to be obtained on presentation. So what do you want to do? What do you want to tell your techs to do? So you want to tell them to get you an IV catheter in. You want to help them facilitate getting IV access into this patient. Because he's a Doberman and he's an older dog, you want to make sure that you aren't seeing any cardiogenic shock. So doing an ultrasound of his chest, a quick emergency ultrasound, make sure it doesn't look like the heart is big or there's pulmonary fluid lines, that there's pleural effusion, any of that, an ECG to look for ventricular beats, any of that would be helpful. And then you want to choose what fluid therapy you want. So this dog had hypovolemia. He was also dehydrated. So we reached initially for crystalloids. We also wanted the team to get our initial blood gas for us. When we look at his blood gas, he's also very hyperkalemic. He is acidotic and he's hypocalcemic. And so again, what do you think is going on with him? Why would we see these electrolyte changes? And does it affect what fluids you would choose for him? I think those are all of our big questions we have to ask. And so on his abnormalities, he has a metabolic acidosis that's associated with a hyperlactemia, hyponatremia, hyperkalemia, hypoglycemia. And again, what is going to be our treatment for our hyperkalemia? What is our top differential? And where are we going to go from here? So for Maximus, he ended up being an Addisonian. So once we started treating him with fluids, we did an ECTH stem, got him started on steroids, and gave him a dose of, we have Zycortal, which is our mineral corticoid supplementation. And within the next 24 hours, his electrolytes had normalized and he was starting to want to eat and holding food down. So all of those things are very, very useful in this situation. So I'm going to skip a little bit to hypokalemia. So we're going to talk about a little bit about ways to treat hypokalemia. Excuse me. So as we talked a little bit about hyperkalemia. So hypokalemia, we have a couple of treatment options. So for intravenous, we need to look out for our potassium max, or our Kmax, which is that we don't want to ever exceed a 0.5 mg per kg per hour. As what our supplementation is. We have potassium chloride and potassium phosphate as ways that we can, and we would never want to bolus a patient that had potassium fluids. If patient, especially these sick cats that come in, they're old, they have renal failure, they have diabetes, they have lots of underlying diseases. They tend to have a very low potassium, usually less than 2 when they present. And in those cases, if the potassium is less than 2, you're going to have a difficult time getting it to be normal with just doing intravenous options. And so you also need to start oral supplementation. You can do potassium gluconate, tablets, and gels. And a lot of these guys, you do end up actually having to add spironolactone also as an aldosterone antagonist. Other clinical scenarios to look at for that is something that if you saw it, it would affect how you would want to do your fluid therapy, but also gives you an idea of things to look for. So for a patient that has a pyloric or a proximal duodenal obstruction, you're looking for a hypokalemia, hypochloridemia, and a metabolic alkalosis. Or cases with severe lactic acidosis, you're looking at a GDV, a hemoabdomen, a pericardial effusion. So if you see those things, all those would give you reasons to look deeper for these potential underlying causes. And I think we are at the end for questions.
Yeah, Dr. Carey, are you able to?
Hello. Yes.
Yeah. Thank you very much for the nice. Sure. Putting out the questions. May I request Dr. Santosh to play the filler? Change one. Thank you, Dr. Santosh. We welcome our director, Dr. S. Balasubramaniam, who is on the line waiting to give the concluding remarks. So we request our director to allow us to go for the question sections. Yeah, thank you, sir. Dr. Carey, we have got 82 questions on the board, but okay. we have selected and limited to 5 questions.
Okay.
Yeah. So what is your real opinion about the use of central venous pressure in field situations, especially for management of critically ill animals?
So honestly, I think that we use it, that I don't use it commonly. I think that it is very useful. I think if it's an animal that's under anesthesia in a situation in which we're doing things like a cardiac procedure, or we're doing a procedure that they have a jugular catheter and we can use it, I think it's very useful. If a patient has a catheter in place and we can use it, I think that the information is available. But if it is a patient that comes in and is not stable enough to have a catheter placed, I think that there's more risk in trying to get a catheter placed and to delay treatment to try to get that information than to try to move forward with doing treatment. If they have a catheter in place, I think it's useful, but I wouldn't go out of my way to place a catheter just to try to get that information.
Thank you, thank you. So what is your suggestion about the catheters, whether we can do the peripheral catheters or central catheters will be fine in those cases which requires fluid therapy or critically ill for 2 or 3 days?
So we use a combination of both in our hospital. So the question was about using peripheral versus central catheters for in-hospital use for a few days. We use a combination of both. Again, I'm not 100% sure if these products are available in India, but we use both peripheral, but we have catheters that via a Seldinger technique, our team can place a peripheral catheter specifically in the lateral saphenous or the medial saphenous in cats, and that they can feed essentially a long line catheter over a wire to basically create a peripheral catheter becoming a central catheter. So we will use those a lot of times. We'll have one cephalic catheter and we'll have basically a long line catheter placed in a hind leg. That facilitates us being able to give medications that potentially are safer to be given through a central line, things like norepinephrine or pressor medications. Sometimes medications that can be a little bit more caustic to skin, such as things like calcium. But we will use a combination of both of them. We'll use a combination of doing a central catheter and doing a peripheral catheter, but that we have, I'm sure it's a human product. I guarantee you it's not just a veterinary product, but it is a catheter that basically we feed over a wire through a peripheral catheter in the hind legs. I can find out the information and get it sent to you guys what company we use, but it requires no sedation. It doesn't require them to have to go under anesthesia to have a jugular catheter placed. It also allows feedback, so you can do frequent blood sampling without them needing to go through frequent venipuncture and losing vascular access. So we use it commonly. Like our ICU has patients that almost all the patients have both a central and a peripheral catheter, but that central catheter is just basically a long line that's fed through one of their saphonouses. In cases in which we know a patient's going to be hospitalized for multiple days, potentially patients that go under anesthesia and are coming out of surgery, we will place a triple or double lumen in their jugular when they're under anesthesia. But again, I wouldn't put a critical animal under anesthesia just to have that catheter placed. I would use using more of these long line catheters. But we will, if they do go under anesthesia and I think they're going to have to be there for a few days, we will place a jugular catheter.
Thank you. We do use central catheters, and it was highly helpful. Regarding, this is my personal opinion, hydroxyethyl starch, it's not very commonly used in human, and they have discouraged in using this because of renal issues. Sometimes it goes for AKI. And then what is your opinion on hydroxyethyl starch, especially in case of parvoviral enteritis or in critically ill pets?
So we don't use it commonly. We have it in our hospital. We don't use it commonly. If I'm going to use head-a-starch, I will use it as a bolus therapy more to try to get a patient stabilized, and then not as using something as a long-term CRI of the fluid while they're hospitalized. We do in some cases, specifically in parvo puppies, end up having to, but in those cases, if we are trying to use it because that their albumin is very low or they're developing vasculitis, we will tend to reach more for doing an albumin transfusion as opposed to, or if they're very small, doing a fresh frozen plasma transfusion to try to help a little bit if they do have parvo antibodies. We have the hyperimmune plasma that we could give them. But we don't use it commonly just for the fact that I don't think we have great evidence to say that we aren't potentially giving renal injury to our patients. And so I used to use it much more commonly when I was in my residency, which again was 13 years ago. It's something that we would use very commonly that had a starch in a lot of patients, and a lot of animals in the ICU were, and that it has become consistently less and less used. And so again, we have it, but we very rarely use it.
Yeah, thank you. So regarding the use of potassium for hypokalemia, advocated use of potassium phosphate. Would you please tell the dose or its availability?
It's a variability. There is a dose. Some of it is, it's a complicated question, but the dose was, what is the dose for potassium phosphate or KPhos? I can send it in an email, and then you guys can send it out to people if they are interested in that. But some of it is dose dependent on how much potassium chloride the patient has already in their fluids, because you have to account for how much potassium you're giving through the potassium chloride, and then how much potassium you're getting from the potassium phosphate, so that you don't exceed that 0.5 as your Kmax. So there's a little bit of a variability. If you're only going to use KPhos, then it's something that you may be able to do a slightly higher dose than if you're using potassium chloride with the potassium phosphate. We tend to use, if it's only for hypokalemia, we tend to usually use just potassium chloride, but it is a situation in which if they have like a DKA that it has a very low phosphorus, in those cases we sometimes are doing potassium chloride and potassium phosphate, but we're using that potassium phosphate more for its phosphorus concentration as opposed to necessarily its potassium. But you have to calculate them both separately and together to make sure you're not going to exceed that amount that could become cardiotoxic to the patient.
Thank you. Do you really have any palatability issues when you use potassium orally?
Sorry, I didn't get the whole question.
Do you have any palatability issues when you're supplementing potassium orally?
Yes. Honestly, yes. There is some issues. We had a cat that is a frequent flyer. He keeps coming into the hospital with a very low potassium. His owners have difficulty giving him supplementation at home. So we have tablets, but the tablets that we have are only 2 milliequivalents. And so for a cat specifically, like this little guy, he's only 2 kilograms. He has an adrenal tumor. They're trying to keep him comfortable. But he would need to take somewhere between like 4 to 6 tablets a day for this. And so it's difficult for any owner to give a cat 4 to 6 tablets a day. And so our tablets are very small. It's only 2 milliequivalents are the tablets. The liquid, we have like a tonic sort of liquid that's more of a sort of less viscous liquid that the cats seem to tolerate a little bit better. The Tumble K gel, I've had a few cats when we've given them large volumes of it, they will vomit them. And so sometimes there is, I think it's called RX pet vitamins, but that it is something that they can get online, but it's more of like, basically it has more of a liquid feel to it as opposed to that gel feel. And I feel like cats tolerate it a little bit better.
Thank you. So there are about 1,830 participants in which 1,431 are on live listening to your lecture. Thank you for the wonderful informative lecture. That's all about the questions. But really what was lingering in my mind, what are those numbers on your background really mean? Are they really indicating the dose or the clients or the case number? Very much.
They're not.
Yes.
So I'm in my home today, and so I'm not working today. But all of those are running badges. So when you do races like half marathons or marathons, they give you badges and then you wear them, and that's what tracks people. So they will have like scanners on the back of them, and it tracks you where you're at and what miles you're at, and then it tracks you. So they're basically running badges.
Okay, so many marathons are okay. Really appreciate that. Okay, so thank you very much.
You're welcome. Thank you for having me, you guys, today.
Thank you, sir. Now I invite Dr. S. Balasubramaniam, Director of Clinics, Tamil Nadu Veterinary Animal Sciences University, to offer his concluding remarks about the webinar.
Am I audible?
Yes, sir.
Yes, sir.
Okay. Very warm good evening to the organizing secretary, Dr. Arun Prasad, the co-organizing secretaries, Dr. Vijay Kumar, Dr. Vijay Anand, Dr. Gopalakrishnan from the RVSS section, and Dr. Ramesh, and Dr. Nagarajan, Professor at Department of Clinics. First of all, I would like to thank our Honorable Vice Chancellor, Professor Dr. C. Balachandran, for having accepted our proposal. And it was cleared only yesterday, day before yesterday. And within 48 hours, we could make this a very grand event. And as Dr. Vijay Kumar has rightly mentioned, out of 1,800 odd participants who have registered, 1,400 were online. So this shows the success and the interest of this lecture. So first of all, let me thank Dr. Carey for having accepted our invitation to present this lecture on the TANUVAS Global Veterinary Trauma and Critical Care Emergency Webinar Series 2, 2021. In fact, your lecture today was very clear, informative, and impressive. And of course, you nailed it. So you have covered all the aspects, the use of crystalloid, the purpose of crystalloid, whether it is just to make an assessment, whether it is hydrated, hypovolemic, then the electrolyte disturbances with the present, then the choice between the normal replacement or maintenance, then the complete classification of fluids which you have given, then the adverse effects, because those things probably are important for practitioners. So the adverse effects which you have very clearly pointed out, like the volume overload, the dilution coagulopathies, hypotension, and of course the electrolyte derangements. And in addition, the inflammatory effects also. So like a pro-inflammatory effect, like cellular swelling, bursting. And when you use the lactated ringer, then the neutrophil activation, then CD18 addition molecule expression. So likewise, the anti-inflammatory effect. And then coming to the colloids, the classification of colloids, like the synthetic and natural, the use of plasma, because the point is well taken, because the poor source of colloid osmotic pressure, which is only 17 to 20 millimeters of mercury. Then you have given detailed aspects of the synthetic colloids, then the adverse effects of colloidal therapy, like the most important, like the renal failure or liver failure, then the allergic reaction, because when you give a colloid therapy and suddenly you can't make an assessment on the failure of the kidney or liver, but the allergic reactions are the first which are going to be shown outside or exhibited, then the overhydration, then how you decide on the fluid therapy, what is the normal fluids, then the fluid therapy in shock, because most of the cases, because this section which has organized this webinar is from the resident veterinary services section, which is an emergency unit. So the importance of shock fluid therapy, how to determine the type of shock. The type of shocks everyone knows, like it is based on cardiac, distributive, hypovolemic, or obstructive. And then how you go about with the hydration therapy, like how you determine the dehydration, then you calculate on the maintenance fluid rate, and then you go for calculation of the fluid which has to be given. And the most important is like subsequently you have gone in with the cardiac output monitoring, and patient assessment. And finally, the highlight of your lecture, which I personally feel is that sharing of interesting cases. Though you have given, due to the want of time, restriction of time, you have discussed 2 case studies, one in a cat, Maverick, and the other one in dog, Maximus. So I think you have given the maximum information, and I am very sure, confident that this webinar would have given additional information to the practitioners, students, even faculty members on how to go about in fluid therapy. So once again, I would like to thank Dr. Carey for the nice presentation. Thank you for giving me this opportunity to give this concluding remarks in this global webinar. Thank you.
Thank you, sir. Now I invite Dr. G. Vijay Kumar, Professor and Head, Veterinary University Peripheral Hospital, to offer the vote of thanks.
Thank you, Dr. Vijayan. At the outset, I am extremely thankful to the organizers and giving an opportunity for this vote of thanks. So on behalf of organizing committee, we wholeheartedly thank the respectable and honorable Vice Chancellor, Dr. C. Balachandran, who has immensely given the permission for conduct of the webinar, and he has presented the presidential address in spite of his busy schedule. Thank you, sir. And the man behind every webinar, and a lovable, respectable person, Dr. S. Balsubramanian, the director of the clinics, who is initiative and then the focus point, or we can say as the pacemaker, and making us to do every work, motivate, and then support us in all actions. So thank you, sir, very much for encouraging us. Then on behalf of the organizing committee, we thank the international speaker, Dr. Carey Hemmelgarn, for providing a very exhaustive and then informative lecture on the fluid homeostasis and electrolyte imbalance. Thank you very much, madam. We thank all the deans of the constituent colleges and the faculties who supported this conductor of the webinar. The organizing committee feels expresses the thanks for the professor and head, Department of Animal Husbandry, Statistics and Computer Application, and Department of Extension Education for deputing the staff and the faculties for providing the IT support and the other activities. We also thank the Dean for providing the conference hall for the successful conduct of the webinar. Last but the least, since we thank every person who has wholeheartedly supported the conduct of the webinar. Thank you very much. The most important point we have to mention, in every webinar we conduct, the technology partner is our Alembic. We wholeheartedly thank Dr. Karunanidhi, who is the Vice President of Alembic, and Dr. Santosh Shinde, AGM Marketing, so who has been supporting this platform through Microsoft Teams. Thank you very much, sir. Thank you, one and all.